Good afternoon and welcome to this webinar that has been organized for this year's Spring European Testing Week, which is taking place this week from the 15th to the 25th of May. My name is Jürgen Rockstruhl. I'm co-chair of the Eurotest Initiative, and I'll be moderating today's discussion. First of all, let me thank you for joining us today. And before we get started, let me just remind you that it's not allowed to use any AI tools to record this webinar, so please deactivate them if you do. The next slide shows you the theme for European Testing Week in spring 2026, which really highlights the importance of focusing efforts on those who are most in need of testing services and where testing gaps still exist. The webinar entitled Reaching the Unreached: Practical Approaches to Normalizing Testing with Key Populations will provide practical examples of how to do exactly that in different settings so that we all can learn from each other. Across Europe, we know that HIV, STI, and hepatitis testing services are widely available, and yet many people are diagnosed late. I have to remind you that ECDC figures suggest that 52% of individuals with HIV are diagnosed late. So that's really much too much. And this is not because testing does not exist, but often because the way testing is offered does not fit people's lives, realities, or experience of stigma or even criminalization. We sometimes use the term hard to reach groups, but this term may be problematic because it blames communities for not accessing our services rather than acknowledging that we fail to ensure access for those who are marginalized or excluded by traditional methods that are inaccessible to them, mainly because of structural reasons. Now, during this wonderful webinar, we'll also ask some poll questions to get sort of a little bit of a blend of what you guys are all thinking. And so we're going to ask you a poll question, which will reflect your own practices. And this is our first poll. So what is the single biggest challenge in reaching people who do not access regular testing services and are in need of testing in your working environment? Lack of awareness among target groups, stigma and fear of testing, limited resources, staff, legal or policy barriers, difficulty assessing the communities, lack of trust in services, or something else. So please vote, and then we'll leave a little time for the voting process and then present the results. All right, maybe we can get the poll results shown on the screen. There you go. All right, so it is different things in different countries. Clearly, stigma and fear of testing sticks out, and I think that that's probably one of the most probable causes of why people don't use services as they are. Obviously, limited resources play a role, and that's something which may be increasing in the current environment, and difficulty assessing the communities also plays a role. All right, thank you for that first poll. So today's webinar will focus on practice, not on theory. So it's really a chance that we hear from organizations that have developed and tested concrete models to reach people who are often missed by traditional clinic-based services by meeting people where they are, integrating testing into everyday environments and working through trust and familiarity. We will have three short presentations, and after each presentation, you have a chance to ask one or two clarifying questions to the presenter. And at the end of the presentation, we'll have a moderated discussion with more broad topics and all your questions you have to the speakers. Please write your questions into the question and answer window so we can address them appropriately. You can send them anonymously if you prefer. Please also feel free to post comments or reflections in the chat. Without any further ado, I'm very pleased to present the first speaker, who comes from the Noaks Ark Mosaic in Sweden. They have developed a community-centered, co-designed, and culturally sensitive integrated testing approaches in Skane and Blekinge, where they have successfully reached so-called hard-to-reach populations, such as the Somali community in Rosengard, Malmö, through trust-building, community engagement, and tailored outreach. So I'd like to welcome Abimbola Ayomale, who's the project manager at Noaks Ark Mosaic, to give his talk. He's a clinician and community health specialist with over 15 years of experience in public health practice, community engagement, and HIV advocacy. His work focuses on migrant health, stigma reduction, and strengthening community-led approaches to HIV prevention and care. So he's really passionate about what he's doing and has a lot of experience, and we're very much looking forward to hear your presentation.
Thank you very much. It's a pleasure to be here. Thanks to the organizers and the panelists. in about 10 minutes. We'll be sharing with ourselves from our lived experiences here in Malmo, Sweden. Can you see my slide now?
Yes, we see them very well.
In a good condition. Okay, yeah. So, in about 10 minutes, I'll be talking about the community-driven approach that we have adopted in Sweden, which has actually worked for us in the south of Sweden, because in Noasak Mosaic, we work in HIV response, particularly for people living with HIV and their family. And we also do integrated testing and we support our people, key population, and particularly migrant population in psychosocial support and also to help them to navigate the system. The story in Sweden is actually, I would say emphatically that it's a good one, actually. However, there are still some gray areas. If we look over what the EU and the EEA area is looking at, like in terms of statistics, 56% of new HIV diagnoses are amongst migrant population. And of course, if we come back to Sweden, in terms of the UNAIDS target of 95, 95, 95, we saw that here we have achieved 99% in terms of treatment and viral suppression, of course, to 98%. However, if we look at the people that are currently being diagnosed, we still have a lag of about 4%. And of course, if we aggregate that 4%, we see that a lot of migrant population are actually testing late. They are having very late diagnosis. And of course, this year, a study was released in March of 2026 from Lund University. It's actually a register-based study that looked at this trend from 2003 to 2023, and which actually gave out that 58% of people that are testing late are actually migrants. So, and the trend has actually been increasing over the time. So, this is actually a concern for us. Well, in Noah's Mosaic, we actually went back home to evaluate what the data actually telling us. 65% of people living with HIV in Sweden are of migrant background. And when we discover that majority of the programs that are designed are not designed actually to target this group. And so if you look at that research from Lund University, you see that the trend has always been increasing since 2003. So that was when we started asking ourselves the very hard question. How do we align testing to the strategies with real world need? How do we actually meet those 65% and not be putting money or resources into where there are no incidents or prevalence, if we want to put it that way. Because in Sweden currently, the prevalence of HIV is about 0.08%, and the trend has not been increasing in terms of new incidents, actually. But when you disaggregate to look at the key population and to look at migrants, then we saw that the need was there. We need to put the resources in terms of health economics to where the problem is. And what we found out was that about 41% of this 65% burden were actually assessing our care. So the kind of people that we are seeing in our facilities were not the representative of the burden here in Sweden. So that we had to sit down and then we had to re-strategize. That was when we came up with a community-led approach that could actually help us. And I will also mention that within this period from 2023 to 2025, we were part of the core program, which was the community response to ending inequality in Europe and part of Southeast Asia, which we were part of that conglomerate consortium, I would say. And also at the same time, we were part of the MI Health, which was led by the African Advocacy. So we learned a lot of other things from partners that could help us where we can use data to actually focus where the problem was coming from. So we came up with that, and then we say, no, we have to go to the society. How do we do that? How do we go to the community? First was we had to raise group of peer workers that understood the dynamics of the community that we want to enter into. So, in collaboration with the Center for Sexual Health and the local CDC, we're able to come up and design a program that would mentor them, that would train them, that will onboard them for them to understand what the challenges are. And of course, we made the community leader more like gatekeepers who we brought into our spaces to actually tell them what the problem was in their society, in their community, so that they can buy into the program. And of course, statistics also have shown in Sweden that within the bigger metropolis, in Stockholm, in Malmo, you have majority, about 40% of this burden in those places, and that is in keeping with migration dynamics. So we also understood that, and that was why we identified Rosengård and Vemmenstugen. Rosengård is a space where we have a lot of migrants living there. Vemmenstuget was also a place where we have people that had challenge with accommodation, who probably temporary homeless and all that. People will also inject drugs. I believe one of the panelists will be talking about that also. So that was why we targeted those spaces. And of course, this is a snapshot from 2024 during the program we had within the core and the MI Health. We had to take the testing, we took it to the public spaces, and then we discovered that after adding other tests within the spectrum of the STI, we added hepatitis B, hepatitis C, and syphilis to HIV because there's so much stigma that is attached to HIV only. So we now discover that even with the 39 or about 40% of the tests that we did in public spaces, we had more infection being identified in those spaces, and then we were able to link them up with care. So, what are the practical things that we need to learn from this? Is that, for example, the faith community was very important and instrumental to our success. Because we discovered that a lot of stigma was driven by faith, by the synagogue, by the faith houses, the mosque, the churches, and then we had to, co-design programs with these people. And of course, ethnic community was also recognized, and then we were able to sit in the table, give them the statistics, and then they were able to buy into what we're about to do for their community. So this is very important for us to note so that we can all learn from it. And the integrated testing also actually help us to be able to peek into those spaces so that they don't see that, oh, it is about HIV only. People will say, no, I'm married, I don't want to talk about HIV. So when we give them all these integrated testing, they buy into it more, and then we're able to go into those spaces to test people. To summarize and round up quickly, it is very important. What we have learned is community trust is very good that they have our trust. We hand the trust, and then peer-led dialogue is very, very important in what we have done that we have learned for. And the integrated testing was also a very good one. The peer support in such a way that language was important for us, that we identify people that look like you, they can talk to you, they have your own lived experience, also really helped us. And we did not leave the community like that. We actually had a protocol that had to do with linkage to care and also retention in care. This was very important for us so that by the time we refer anyone that was reactive, we could follow them up with the protocol we have with the Center for Infectious Disease. And these have actually been working. Sometimes when the doctors from the hospital don't see them, they call us so we can actually trace them into the community and bring them back to care. So these are some of the very important things that we learned. Community partnership in co-designing those programs were very important. Low threshold testing, so that we can test everybody at the screening level, and anybody that is reactive, we can actually send them for care. And of course, cultural competence. Sometimes the Somalian community will tell us they want the women only today, and then maybe in another week or in another month, they want the men only or the youth only. So we always abide by that, and then we go by their suggestion, and that has actually worked very well for us. So my final thoughts are there are no hard to reach population, except that whenever designs are made in terms of interventions, people that actually need it are not at the table. So the power dynamics is something that we must really fight so that we can have health equity for everyone. And also, very importantly, is meeting them in their safe spaces. Because that also stood out for us in all of our programs. And people will be receptive if you come into their spaces. And of course, sometimes they ask us, can you do training for us at 6 p.m.? Sometimes we are there up to like 9 p.m., even up to 10 sometimes. So those are the things that we need to learn. Otherwise, we'll keep missing these people, and then we'll be labeling them hard. So I want to thank everybody that are listening. I hope we'll be able to learn one or two things from ourselves. So community-led testing must move from the margin to the center of public health strategy. Thank you for your time.
Thank you very much. That was a great presentation, and I think a great example of how if you involve the community, you can change your testing access and paradigm. So that was very good. If you have questions directly clarifying content, please put that into the chat. Otherwise, we're going to follow up with the second poll question, obviously somewhat in relation to what Abimbola talked about us. And we just want to see, how does your organization actively involve members of key populations, as we just heard it was so important in his testing efforts in designing services. So please let us know whether you also involving members of key populations, no, or planning to, or not sure. Thank you. Please vote now. And while you're voting, I think the other impressive thing was that you showed how integrated testing reduces stigma. I think that's, and we remember that that's one of the big things Eurotest and testing week sort of developed, this sort of the emphasis on integrated testing. And I think that was a great example of showing how that normalizes sort of the whole testing procedure, which is a very great example. Great. So I see not everyone is involving key populations. So is a large group though who's planning to. So maybe this was a good example to encourage people to actually involve the communities they're taking care of, to be in the process of helping develop testing programs. Great. So with that, I think we'll move to the next presentation. I don't see any questions in the chat room. So we're going to look at our next presentation, which is really looking at normalizing testing in a very different but equally important setting. Our second speaker is Jenny Kasinen Wickman from HIV Point, Finland, so a different country, who will present experience from the Right to an HIV Test project. Jenny is a harm reduction outwork specialist at an A-Clinic Foundation, working on the Right to an HIV Test project in cooperation with HIV Point. She has extended years of experience in substance use work, including low-threshold street-based and outreach services supporting people in vulnerable situations, and she will share how HIV and hepatitis C testing has been embedded into routine practices with people who use drugs in settings such as housing first units, and also how European Testing Week itself has been useful as a tool for implementation and change. Obviously, something we love to hear about. So, welcome, Jenny, and we're looking forward to your presentation.
Thank you very much. And I have to say, first of all, that there is two Jennys at the time, and we're going to share the presentation. But thank you for inviting us. And here we go. Jenny Tigerstedt will start our presentation.
Yeah. And I work at HIV Point as a head of prevention and services. So very nice to be here. Thank you for inviting us. So we can go to the first slide. So we're going to tell our project. It's a 3-year 3 years lasting project, and we have the last year going on right now. And it's a joint initiative by HIV Point, which is an old HIV organization founded 86. And then we have a clinic foundation that works mostly with substance use issues. And it's the main goal of the project is to improve HIV testing access, reach, and timeliness for people who use drugs. And this is done in low threshold services like day centers, housing units, street and mobile services. And that the services that already exist. So we are not creating new services in this project. And like little bit background, so we had a really bad epidemic in the beginning of the 2000, and after that only few new infections, but then there was a new HIV cluster in the capital area during the 2018 and 24. It was 30 something new cases, so not like a huge epidemic, but still it was a different for the situation that we've had for almost 20 years. So that was made also a good momentum for this project. And this presentation that we have is based on surveys that we've done, practical observation and materials, trainings, workshops, and that we've gathered from both service users and professionals. And maybe in the beginning, what Jürgen said, it's this key message is also in this project that the right to an HIV test exists, but the service system does not always make it easy to access testing. Also, this happens in low threshold settings. And we can go to our next slide. And we worked in the area of whole Finland, but especially in the capital region. And like I told, we worked in these services targeted to drug users. And it was housing units, day centers, outreach settings, and health counseling services for people who use drugs, and especially people who inject drugs. And current situation is that in quite many of these places, HIV testing is formally available, but it's not always easy to access for the service users. And when we have low HIV cases, that may mask insufficient testing coverage. So that's a big problem, but because and these key barriers are probably the same that many of you recognize: is stigma, fear, lack of routine testing offering, unclear pathways, and practical access issues. And also there's a lot of missed opportunities. Many of these people visit healthcare services quite often, but blood samples are taken, but no HIV testing is offered.
And next slide, please. Thank you.
Yeah, and a little bit background statistic from Finland. So we have around 25,000 people who inject drugs living in Finland, and drug-related deaths are growing. And in 2024, there was 247 deaths, and clean injecting equipment distributed approximately 7 million per year.
And the next slide, please.
Yeah.
And as you can see on these statistics, HIV numbers are relatively low in Finland, also among people who inject drugs. But as you can see, the hepatitis C remains a major concern in Finland. So also the hepatitis B epidemic among people who inject drugs is continuous. So as we know, HIV, hepatitis C, and also hepatitis B have the same route to human transmission route. So that's the problem. We can't say that we have a low HIV numbers if we don't test enough. Of course, we do know that there's just a few HIV infections among people who use drugs in Finland at the time. But as you can see, hepatitis C and B are still going strong, unfortunately. And next slide, please. The method is next is how we worked. So we worked in the places where people already are. Housing units, that means housing first units, low threshold services, day centers, and outreach environments. We use both a staff survey and client survey to identify barriers, workable testing pathways, and what makes testing acceptable in practice. So the staff survey, there was only 31 answers we get. Anyhow, 55.6% reported that they are already testing in their own unit. 37% said that public outreach services are testing, and 11.1% said that they are third sector actors. Service user involvement do matters a lot. Barriers and solutions were explored together with the service providers and people using the services. We wanted to understand both service reality and client reality, not only where testing is possible, but where it is acceptable and likely to happen. And next slide, please. The problem we wanted to address. Well, let's say low record HIV numbers do not mean that there is low need for testing. As we earlier showed, there is a lot of hepatitis C and also hepatitis B in Finland. The issue is not that the HIV risk has disappeared. The issue is that low testing can easily create a false sense of safety. And what I mean, it can make false sense of safety mainly on the staff. If we don't ask, if we don't offer, and if we don't remind people who are using services, low threshold services, that it's good idea to get tested every third month, and if we don't provide information, then there is no testing at all. And next slide, please. Well, our findings then. Our findings show that the issue is not simple unwillingness. The barriers are structural, practical, and relational. HIV testing should be planned around the trust, safety, and everyday service contacts. The key question is not only where can people get tested, but where people already are and who they trust. Without the trust, there is no testing. And what I mean is, if staff don't trust that they have skills, they have enough knowledge, and it means that staff won't be offering tests. And if there is lack of trust among people who are using the services, they won't go and ask the testing. And next slide, please. What we have done and what we are working on now is kind of a guidebook for low threshold services. And there's a few infographics about what we have already done. But the main thing is that we have to build trust on those already created in low threshold services. With the staff members, we have to normalize HIV testing as part of the routine harm reduction work. Because harm reduction work is a lot of more than just clean syringes, needles, and using equipments. What makes it work is it maintains voluntariness, confidentiality, and client autonomy. Also, it's very important. Uses non-judgment, stigma-sensitive communication is one of the key factors. Flexible model fits the different service environments. And there you can see there is low threshold testing pathway. There is three different kind of testing routes, but the pathway is same for all. Success depends on the trained staff, clear instructions, test availability, and agreed follow-up pathways. And the next slide, please. Our recommendation for others is do not assume that staff or service users already have sufficient knowledge about HIV, hepatitis, or sexually transmitted infections. Provide regular training and up-to-date information for both staff and service users. Set the clear testing targets for each service settings, because the service settings are different. Document whether testing was offered, accepted, completed, and follow up those. Monitor testing volumes and outcomes regularly. Evaluate implementation and adjust practices based on data. Integrate HIV testing into routine workflows, not occasional campaigns only. Use data for learning and quality improvement, not blaming. And the next slide, please. What supported our success? European Testing Week. It was included in every our partners' weekly annual calendar. There was clear planning and defining goals. Both quantitative and qualitative targets was set. Goals are agreed together with the staff, and also the service users was implementing on that work. And also leadership support was very important. Testing was offered to all the service users. It was visible promoted at the service location. Targeted testing twice a year, especially in housing units, can be reach almost every client. And we have shown that there is one housing first unit that last spring and last November, they tested in the European Testing Week almost 100 occupations twice in a year. And they have little bit more than 100 occupations. So this really works. Follow up and evaluate your essentials. The need is there. Both clients and staff show that HIV testing is relevant in these settings. The main barriers are practical and structural. Supplies, training, clear instructions, and follow-up pathways do matter a lot. Low threshold HIV testing works best when it's routine, respectful, and co-developed and measurable. Our key lessons learned is availability. Low diagnosis should not be interpreted without knowing testing coverage. Trust frontline workers and central to acceptability. Testing works best when embedded with broader harm reduction support. Low threshold HIV testing should not be treated only as an emergency response. It should be a normal, visible, and supported part of services for people who are using drugs. And there is one more picture about from our guidebook. There is confidentially minimal documentation, preventive and harm reduction work, clear pathway, goals, monitoring, and evaluation. Thank you.
Perfect. Thank you very much, both Jennies. That was really wonderful. And I think it really illustrates very nicely how important it is also to dig into your own data and have an evaluation of coverage of testing services and how it's done and what the clients say and what the service providers say, because then you can learn how you can fill these gaps and improve things. So I think that was a very good example of how you also analyze your own population to make it even better. I think we're going to move directly to the next poll question because we're a little advanced in time. We can have that. So, which of these would be most important factor for being able to implement new outreach testing approaches that ensure better access for key groups? Please choose one of those listed important factors for being able to implement new testing approaches. And while you're voting, one of the questions I would have later, maybe we can pick that up in the discussion, is around the HBV epidemic you have in people who use drugs. And the question is, couldn't that also be combined with testing that those who test negative, for example, for hepatitis B, would there be a possibility to get them somehow into a vaccination program? Because obviously that would be key for preventing hepatitis B. All right, maybe we can see the results of the poll 3. All right. Well, that's great. So most people feel that partnership with community groups are very important to implement new testing approaches, and that obviously is good in line with the two presentations we heard so far. Thank you very much. And now we're going to move to the next and final presentation for today, which comes from Magdalena Ankestein-Bartoszek from the Foundation for Social Education in Poland. She's a PhD, a social scientist, sexual health educator, and president of the Fundacja Edukacja Społeczna, and my Polish is not the greatest, in Warsaw. She has over 20 years of experience in HIV prevention, harm reduction, and community-based public health, and coordinates community-based testing counseling services as well as national and international programs. She's a lecturer at the Medical University of Warsaw, active member of the EATG, of the EX. Her expertise includes HIV testing strategies, linkage to care, stigma reduction, implementation research, reflected in numerous published papers and international projects. She works extensively with young people, key populations, advocating for accessible community-led prevention, integrated health services with a strong focus on reducing inequalities and improving early diagnosis and care. So we're really looking forward to her presentation. She clearly is an experienced advocate in this area, so we're looking forward to your talk.
Thank you very much, Jürgen, and thank you for the invitation for the webinar. I'm also happy to be co-chair of the European Testing Week, so for us it's very important time during the year. But today I will be mainly speaking about our experience from Foundation for Social Education. We are a non-governmental organization based in Warsaw, in Poland. So very quickly, because we don't have too much time and I have a lot of information that I would like to share, small background from Poland. You have to know that only 10% of adult people in Poland had ever tested for HIV in their life. Unfortunately, it's not very popular, and only last year, in the beginning of May, HIV test was included for the GPs. We have voluntary counseling testing centers, 29 in all over Poland, but still it's not so popular. Why it's not popular? Because 87% Polish people think that HIV is not their problem, and there is also stigma and discrimination, and people think that only gay men, sex workers, and people who using drugs get HIV, and white heterosexual women probably will not go for testing, and is also presented on the testing for pregnant women, even though that gynecologists should offer for all pregnant women, less than half, even some data showing that 30% had tests during the pregnancy. Access for treatment in Poland is for everybody, but it's still based on the public insurance. So if you don't have insurance, you have to pay for the visit and then get treatment for free. And the sad information is that more than 44% of newly diagnosed are late presenters. And the shocking information that it's still 19% people died after 6 months after diagnosis because it's so late. And unfortunately, this number increase. What I know from my colleague from clinicians, they saying that they haven't seen so many deaths like it happened in the last month. So we have to do something, but it's not time for that to saying about it more. But in Poland, PrEP, it's only it's not reimbursement, so we don't have access if you don't have money. So this is the statistic, and this is the reason why we don't have combination prevention, or this is the result of the non having a good combination prevention program and no access for PrEP. As you can see, numbers still growing up. Of course, after 2022, we've had more migrants from Ukraine, but as you can see, it's not what is sometimes you can find on the different report that government blaming that the increase coming from migrants. No, it's not true. We are still increasing number for years, and nothing happened because if we don't have combination prevention program, we cannot stop epidemic. And this is also what's going on around STIs. It's also similar. Chlamydia, gonorrhea, it's the number it's increased. And we know from our doctors that it's not the real data because many cases of syphilis are not sending as a data for the public institution of health. So what we are doing, we are one of the 15 organizations in Poland concentrate on the testing around HIV. We have quite big experience because we have 24 years. And as you can see, we are doing almost everything around HIV, just do not prescribe treatment because we are not a doctor. We are testing, we educate, we organize campaign about stigma and discrimination. We are doing a lot of advocacy work and also international collaboration helps us in the implementation of the research and many international programs. But today, of course, I will be mainly speaking about our testing program, but you have to know that we have directly linkage to care for and coordinate communications and good cooperation with the clinician. And also we have support program for people living with HIV and their friends and family. So everybody who needs treatment, who needs support, get it for free in foundation. And also all our activities in foundation is free of charge for our clients, so they don't have to pay for anything. And this is our journey around HIV testing. We started first our voluntary counseling testing place. We opened in 2003, so we are 21 years experience. And the voluntary counseling testing, it looks like a checkpoint in Europe, but it's mainly for general population. Of course, our mainly clients are men who have sex with men, but still it's for all, not only for MSM like in many checkpoints. In 2017, we opened the first mobile harm reduction service. We rent the camper. We implement this project from the Red Cross from Rome, and we start testing people who using drugs, mainly in Warsaw, but also we are traveling because we have cars, so we can travel for different places, the therapy center, but also in the last few years, also for migrants population shelters, and use this opportunity that we can travel for different place. But mainly from 2017, we concentrate also the voluntary counseling testing places. We have right now 2 and one that we are testing. And we are only one organization in Poland who have this kind of testing by with car. In 2018, after Integrate project, we implement HIV, hepatitis C, and syphilis testing for our voluntary counseling testing. And we also start doing outreach testing because we find out that our clients in the voluntary counseling testing, it's not the main population that we should have. We have around 1% positive results in our voluntary counseling testing. So we also know that we need to go outside of our testing place to go directly for those people who really need testing. In 2020, we use opportunity of COVID time, and we implement self-testing because it was lockdown, voluntary counseling places were closed. So we directly implement self-testing as a piloting project, and if we have money, continue this project until now. So we are also only one organization who have continuation from 2020 self-testing, and unfortunately we don't have funding for government. And in 2022, we increase our integrate testing to TB, because we have more and more migrants, and LHL International, the organization from Norway, support us with funds, and we implement also for our testing TB screening questionnaire, and all our team had a workshop around TB. So where we are doing almost all key population, I think, with testing. As I mentioned, we have this voluntary counseling mobile for people who are using drugs, but also last year we started piloting project for migrants, and also starting piloting project for prisoners. We have a very good collaboration with prison in Poland, and we are right now 1,000 tests for prisonal HIV, hepatitis, syphilis. We send still self-tests. We also testing on the Pride. Very quick. Next month we will have the Pride again in Warsaw, but also in other cities. So we try to go to the key population. We also going to the clubs, saunas, LGBT community bars, and offer outreach testing there. So this is our activities on our team on different place. This is mobile harm reduction service, so Camper, and until now we have more than 100,000 tests on the voluntary counseling testing, more than 1,000 positive result on the voluntary counseling testing. But as you can see, we have also high number of HIV on the mobile harm reduction service, but also on the prison, even though it's less than 1,000 tests, 41 positive results of the hepatitis C. So it's also quite big rate. And as I mentioned, we last year, with collaboration with WHO, implement testing for migrants, and it was very interesting for us. It was a very good collaboration with WHO Poland. And we hope to continue it because we see that it's a huge need, because we also see late diagnosis on this population. And why it's so important to expand testing. This is some data from our from our experience. And just to let you know, first of all, on the voluntary counseling testing, most our clients are men who have sex with men, and most of them are regular testing. But as you can see on the slide, that also that extremely different option is on the self-testing. Most our clients are women, and they had never tested before. 75% people who ordered the test for free had never the test before. So we see that we have to offer different option of testing for different people. So this is also the gender. As you can see, there's different what I mentioned before. And on the outreach, as you can see also, not only men and women, but also they're coming for us for testing. So it's also, again, the key population, people who are testing with us. And it's also the difference between age. Younger people order self-test, or older people coming for the regular testing on the voluntary counseling testing. And also, this is our activity of the core project of the self-testing. We have the professional website you can order for free, and it also works very well. We still promote it and also collecting data and show on the government that it's really needed to have funding for the self-test for HIV also from governmental level. So to finalize, it's very important to not only testing, but testing should be part of the combination prevention option. So that's also the problem for us. If we cannot send person for the PrEP, if we see that if somebody is coming regularly and testing, it's not the prevention as a general. So if somebody is coming regularly, sooner or later, this person can have positive results if it doesn't change the situation of the way of transmission. We know that if it's only voluntary counseling testing, stationary, we have to open the door and go for our clients and go for the key population. We sometimes, especially when we are doing outreach, we are testing on the gay sauna, and for 30 people, 10 people coming for tests, and it's during the night, but we have 2 positive results. So we go directly for the population that we need. And we should offer different options, because some people really like to come to the voluntary counseling testing place, but other people will never come for this place. And we need to offer them outreach tests and self-tests And for sure, this kind of service should have continuation of the funding. It should be mandatory for the long-term strategy. And thank you for your attention.
Thank you very much, Magdalena. That was really impressive. This 23-year journey of testing in many different ways. I was very impressed also about your prison work. Can you say something, though, because you have quite a number of high diagnoses, if you think about it, for 1,000 tests. Can they be linked somehow to care? Is it possible to get them
Yeah.
to hepatitis C treatment?
Yeah, we had invitation from the prison, so it was great because they opened door for us, and they have their own medical hospitals, so they have access for hepatitis C, and right now it's ongoing project of the treatment for hepatitis C for prisoner directly in prison. So it's very important because they have a linkage directly in when they are staying in prison, they will get access for treatment for hepatitis C.
Wow, that's very impressive because you know that in many countries, treatment in
Yeah,
prison is one of the big limitations.
National AIDS Center had a dedicated program for 5 years, HIV, and they include also treatment for hepatitis C for prisoners.
Okay, great. Oh, that's fantastic. All right. So these were three wonderful presentations. So I hope you enjoyed and got something which you can say, wow, this is something I can take home and also use for my testing efforts. If you have questions, I think this is the right moment to enter your question into the chat, and we'll be happy to address that. And as we're waiting for questions to come in, maybe I can start with an opening question, because all of you sort of touched upon how you improve your testing programs, but what was really surprised you most why people were not accessing testing, although services were available? So in Sweden, obviously, there are testing services, but they don't reach all the different people who need them. So what surprised you the most? You have
From our needs analysis, we discover and our interaction with people, we discover that stigma was actually one of those things that made people want to push back. For example, some persons have told us that, oh, if they see them in our space, somebody can think that they live with HIV. However, we provide services beyond testing. In fact, we support people who probably just came to the country, they don't have the language. We help them, for example, to interpret their letters that are sent home. In fact, we do what we call the Sprock Cafe, that is a language cafe. We have support for people to pick up the languages. If they have assignments from language school, we help them with. So that stigma was a major one that was making people not want to come at all to access these services.
I think that's a perfect example. So what you're saying is that if you also tie in other services, or let's say something which is even not HR related at all, then you have a much bigger probability of uptake in that particular
Exactly.
group. Yeah.
Exactly.
Yeah.
Yeah.
Because I can share that, like, I work in a NGO in Cologne, which is a checkpoint, which is open for everybody, but migrants don't go there just because of this.
Exactly.
Going there already basically implies that you might have HIV, and so per se.
Exactly.
And that's why I think this aspect of cultural sensitive, addressing services in a way people feel that it's not putting them in the spotlight is very, very important.
Exactly. Yeah.
I guess in our project, one finding was that the work culture makes a huge difference in these settings, like especially when it's like these housing settings. There are like kind of similar housings where in one place they can really test and promote testing, and then in another place it seems to be almost impossible. And when we look at it, it's not about resources, it's not about space, or definitely not about service users. It's like the work culture. Some people are just, okay, this is housing, we are not doing anything else, and the staff might be really passive. So this is something that we found.
Yeah, the bottleneck for low testing rates is it's on us, the staff, not on the service users. And one other thing also is that I have lived through the in Finland that early 2000 HIV epidemic among people who inject drugs, and it's frightening to me here. Young people who use drugs, injecting drugs, that they think that HIV is like a seasonal flu,
Yeah.
that you can take a shot and it's over. That means that I and my colleagues, we haven't done our work properly. We haven't do right things. We haven't spread the message.
Yeah. Well, I think that's a great point. And you highlight the need for continued education and that we can't just believe that everyone knows everything. And obviously also what HIV and AIDS stand for are changing and there are different perceptions. And that's so young people see this very different than people who were born when the whole first cases appeared. So that's absolutely right. So Magda, you showed up and then Cecilia.
Just short comments. We also saw when we integrate testing, before we only dedicate HIV testing, people didn't want to come because they were afraid of stigma. When we implement hepatitis C and syphilis, people, we find out very quickly that increase the number of people who are coming for testing. And there were no problem when we offer free tests. It was problem only when we dedicate for one test. So the integrating testing, it's very helpful for the barrier. It's to fight with the stigma also.
Perfect. All right, so we've reached the full hour. Let me thank our wonderful presenters. I think we heard great examples of how you can improve testing services and give access to people who sometimes have difficulties assessing services which are there. So let me end with a poll question. How relevant and valuable did you find this webinar for your work? So we get a little bit of feedback. Please vote now. I'm always intrigued when I see, how dedicated people are in building up, trying to sort of get better programs ready. And I love the idea of also analyzing what you're doing to see where are there niches where you could sort of improve, and things like reinforcing that there's a need for education, that perceptions are changing, rolling out to all kind of different populations, like seeing how Magda over time has reached all kind of different populations, including the ones in the prison, and building up programs, linking them to care. I mean, all that is very, very, I think, motivating in a certain sense in a world where not a lot of good news are happening. So wonderful. And I hope that all continues and you all participate eagerly in this testing week. And thank you all for joining. And I don't know whether we're going to see the result of the poll. We're not going to see the result of the poll. That's going to be the secret for Cecilia. So thank you all for dialing in. Thank you for organizing this. And I wish you all a wonderful upcoming weekend, and best wishes.